So hopefully it's going to be worthwhile listening to me, because it sounds like we haven't progressed that much, but I hope to dispel that we did make a difference during the last 10 years that we conducted the audit activity. Yes, there's always room for improvement, but hopefully I can show how worthwhile the journey was and perhaps what direction we can take safely. Okay, so for those, because I know there's a few people that have never heard of VASM, and I know there's a few consumer representatives, legal representatives, nursing staff, academic staff that probably never ever heard of VASM or have peripherally and just superficially know what we are doing. So I will give you a very brief overview, but I will try not to overdo it, because we heard a little bit from Ewan about the VASM processes, and Trevor has covered quite well some of the outcomes from last year's reports. So the origins actually come from the Scottish Audit of Surgical Mortality, and in 2011, James Aitken, the clinical director from Western Australia, implemented this audit in Australia. In around about 2007, around about the time when Dr. Det surfaced in Australia, all major states have joined the audit activity, and there was VASM as well. So in 2007, we commenced the audit activity. And by 2010, all states and territories have joined forces, and we now form an NZASM platform. Our counterparts in New South Wales actually follow the same audit process, even though they are run through the Clinical Excellence Commission, and they're protected by the same qualified privilege as VASM and NZASM is protected under. So who are our collaborators? So you would have heard about our counterparts. So VASM stands for the Victorian Audit of Surgical Mortality, QASM for Queensland Audit of Surgical Mortality. So obviously we are forming a wonderful platform, and we are doing the same things, and we are able to compare things not only by state but nationally, and I think that gives power to the audit activity. We also collaborate with 192 surgical hospitals, and I just discovered last month that there's a new hospital that we are still ought to recruit in Victoria. So any new surgical site that appears in Victoria, we aim to include to have 100% compliance in reporting. We have 2,400 fellows. These fellows are not only necessarily fellows of the College of Surgeons. We collaborate with the Orthopaedic Association, and we started collaborating with the Royal Australasian College of Gynecologists in 2012. And of course, we're working closely with, as you have heard, the VCAM committee, the Victorian Surgical Consultative Council, and also Safer Care Victoria under the premises of the Department of Health. So when we commenced, obviously, dinosaur times, we started everything on paper, everything was slow. It took us approximately 7 months, to do the journey of the assessments and the peer review process. In 2012, we moved on to an electronic platform, being aware that it's so important to provide very quick, efficient feedback to our fellows. So as of last year, we have mandated this electronic submission. So what is the true audit process? Because I know some hospital representatives only report data to us, and some hospital representatives only look at the report, and sometimes there's no overflow of communication among departments about the audit process. And I still have meetings with some of our hospital stakeholders that don't understand the true flow, the audit flow. So for the benefit of VASM, I would like to explain the audit flow. So we receive notifications from the hospitals, 80% of those. We receive approximately 10 to 15% from true coroner's depositions. We also receive self-reporting from the treating surgeon. We receive reporting from sometimes anaesthetists or other clinicians within the hospital, and on very rare occasions, actually from the patient's relatives. So we accept any notification of that from any sources available, and we start the audit process. The audit commenced in 2007 as a volunteer program, and it was set up for an educational activity. So our main focus, the main target here is education, and we would like to remain an educative tool yet implement some of the recommendations that we have heard in the past. So how does this educational journey start? We request the treating surgeon to complete a form. It's a very lengthy and time-consuming form. Unfortunately, we can't apologize for that because we are trying to utilize it for a good cause, to save those lives, as Ewan said. So the form contains some of the demographic data, some of the clinical data, operative data, but most importantly, contains a question about would you do something different in that particular scenario if it would occur again. That reflective section starts the audit process. In retrospect, it's always easier to identify problems, and I will talk why it's so important to have that retrospect. So once we receive that information from the treating surgeon, the case gets de-identified and gets sent to a first-line assessor who's a surgeon from the same specialty but from a completely different hospital, to ensure that the peer review is unbiased and perhaps, a trainee can actually review a surgeon's case, or maybe an outdated procedure can be commented on. So we try and utilize a very transparent process. The first-line assessor will come back and provide us feedback if the case had no issues or had minor issues, and I will elaborate on that a little bit later, or there were some issues in the patient care. If there were issues in patient care and it caused the death of the patient, those cases get sent for an in-depth review, similar to a medical legal review. But those cases can only be utilized for educational purposes. So for that particular scenario, we contact again the hospital and request the medical records in a de-identified manner and provide them to a second surgeon who is from a different hospital of the treating surgeon, different hospital to the first-line assessor, from the same specialty and ideally exactly the same subspecialty and similar workload to the treating surgeon. This is ensuring that we're truly comparing realistic experiences and we are not biasing subspecialties and providing incorrect feedback to the treating surgeon. So once we receive this report, we provide it to the treating surgeon, but we are not closing the loop of the audit there. We're also providing that information to the first-line assessor who originally raised those questions and was concerned about the patient care. So this is passive learning not only for the surgeon himself or herself, but also for the first-line assessor. And the surgeon, the second-line assessor, who's having all the information available, is going through that educational journey because he's doing research on most relevant publications and most relevant recommendations for that particular case. So that educational journey continues. Again, the audit loop is still not closed because the treating surgeon, when it receives the report, has the option to appeal, to question the criticism. In the 10 years that I have been managing the audit, we had 7 appeals. So most times the treating surgeon acknowledges, yes, there was room for improvement. And in the few cases, the subspecialty, it wasn't quite appropriate when we selected those cases. And those can be very, very tricky, particularly when we talk about pediatric cardiothoracic surgery. We really need to ensure that we choose quite an appropriate and skilled assessor for those cases. So now the audit loop still hasn't finished and the educational process hasn't finished. Yes, we have informed all the surgeons about the cases, but we are providing aggregate reports, as you would have heard from Ewan and from Trevor. We provide those reports not only to our treating fellows, but to our hospitals, of course, in any institutions in the registry groups to disseminate important messages. We analyze the data both quantitatively, obviously utilizing an epidemiological perspective, but we don't forget about the patient's journey. We don't forget about those stories, and we utilize qualitative analysis and we disseminate messages through those qualitative clinical case note review booklets as well. So what are those real issues? What is VASM's purpose? Of course, reducing mortalities, but how do we identify them and how do we reinforce that educational process that we set target for? So the very first point is the area of consideration. So we already heard from Trevor about the patient that is admitted as a fractured neck of femur. However, there's a difference in opinion. And if you ask any orthopedic surgeon, one perhaps would decide to palliate and one would decide to operate. VASM gives the same platform of communication, a journey that surgeons can take and talk about it rather than a punitive approach. You have done the wrong care for this particular patient. And we can talk about these issues openly in specialty annual scientific meetings. Though our true purpose, as you have heard, are those areas of concern and adverse events. So the area of concern is when we identify that the patient care should have been better, or adverse event where the patient care was caused by some sort of system error or technical error at a hospital. So you would have seen some of the last year's finding, and you would have seen the last year's annual report results, but this is from our current embargoed report, and some of the information, yes, does remain stale because we're talking about clinical demographic. So when we look at our patients, we heard about frailty, but the reality is we only look at mortalities. We only look at a very small proportion of those patients that underwent surgery. We do not have denominator data. So our patients are old, frail, with several, 90% of them will have comorbidities and with a mean of 3 comorbidities. And we know that there's usually issues in transfer and delays. And we also know that the risk of death was very, very high, even prior performing the surgery. Is this excusing us from, not recognizing that there's problems? No. We do monitor all those areas and risks during the patient journey. And yes, there are complications. There's a slightly lower rate return to theatre rate from 16 to 15% this year. And we know the causes of death remain stable because we can't change the comorbidities, the cofactors. The patients will present sick and frail. So we know those causes of death through the years will remain constant. However, what we can truly change are the outcomes. And this is where we put our energy into. So the reality is that humans will cause errors. In any industry you look into, humans will cause error, and the margin is approximately 5%. So when we look at the data, we can see that we have identified 4.2% adverse events related to surgical deaths since 2012. You're asking me, why am I talking from 2012 onwards? It's not because I don't want to present a picture from 2007. That's when the college mandated the audit. And that's when we know all our surgeons have reported their surgical mortalities to us. So it's a thorough and neat and clean set of information, and it wasn't voluntarily reported, it was mandated. Yes, there are areas of concern, so we don't want to see those areas of concern. We would like to see those areas moved into area of consideration, perhaps debatable differences in opinion. When we look at the association, you will see that most issues have been, so there are 72% no issues whatsoever, but in the majority of cases, 19% were related to the surgical team. Is this a surprise? Well, I could be biased, but we set up this audit to improve surgical care. So of course it's going to be addressed to surgery because the surgeons will go in, those assessors will go in and try and identify specific surgical errors. So our main focus is to treat and to anticipate, what kind of improvements we can do in the surgical arena. But in the process, yes, we are likely to identify other problems as well that are related to hospital protocol, clinical teams, ambulance services, patient-related factors. So overall, we know we're identifying issues. So the question is, what is the story? How are we showing that we're improving? What is the trend? How are we making a difference? So in the last 5 years, we have been looking what are the most common preventable clinical management issues. And as you can see, they are pre, intra, and post-operative surgical issues, again, we are focusing on surgical errors. So please remember that that is our primary focus. But we do identify other areas as well, delays and hospital-related protocol issues that are not followed. So how valid is this information? Initially, when we started up the audit process, people would say, oh, surgeons are protecting themselves, they are not being honest, they are not telling the truth. In reality, we do a lot of checks to ensure that the quality of the information that we are receiving is as accurate as possible. Not only we compare the opinion of the treating surgeon to the first-line assessor, the first-line assessor to the second-line assessor, we also compare the opinion of the treating surgeon and the second-line assessor on clinical management issues. And we know that the second-line assessor will always come up with more issues than the treating surgeon himself or herself. The peer reviewer, the second-line assessor, as I said, has the luxury of the retrospect, can think, can investigate, can identify areas of improvement, while the treating surgeon has to go on the go, has to handle all the situation as best as he or she can, given that time frame. We also look then at validation. Is this peer review process reliable? Can we replicate it? How honest are these peer reviewers in providing that information back to you, in providing true criticism about the patient care? So last year we conducted 97, our goal was to conduct 100 cases, but 97 first, second-line assessment. So what I mean by that, in 97 cases, we sent out exactly the same case to a completely different assessor to see what will be the outcome. Will we receive the same feedback? And again, the error margin remains what's expected. It was just above 5.6%. And we did the same thing with second-line assessment. So to remember this is the in-depth medical legal investigation that we're conducting on cases. And we noticed that exactly the same, the outcome was the same recommendations were coming out from the second-line assessor. So we know there's some validity in the information that we are receiving, and there's some value. So therefore, we can safely report back on performance to our treating surgeons. So we have created hospital and individual surgeon performance reports. Yes, these reports are not available publicly, but the surgeon can decide to produce these reports and talk to patients about his or her performance. We look at areas of clinical management, but most importantly, we look at preventable clinical management issues. We cannot impose the treating surgeons to utilize this in the discussion with the patient. Again, our role is educational at this stage, and that's what we are focusing on. However, those tools are available, and the surgeon will have his performance or her performance compared to peers in Victoria, but most importantly, also peers in the same specialty across the nation. We're producing also clinical governance reports to the hospitals. When we started producing them, I understand a lot of hospitals didn't know what to do with it, where to take it from, how this information can be utilized. And now this is the third year, and I'm getting a lot of good support. We have been going out to hospitals. There have been a lot of grand round meetings where VASM data has been presented, and a lot of clinical governance managers and directors have been approaching us to discuss further improvement within their own hospitals. So you would be pleased to know that VASM would like to utilize this information as a positive learning tool rather than a punitive tool. And yes, we have invited Hospital 129, and you will find out very soon who Hospital 129 is. But we have also identified a lot of hospitals that perform well. They're probably not in green, but they're definitely performing well, and they will be speaking to you today. So hopefully we can learn from their journey. We can learn from the experiences, and you can compare perhaps public versus private, trauma versus regional. So we can gauge the challenges within each individual hospital. So when we look at this particular clinical governance report, so when the hospitals receive it, just a comparison, and we talked about a return to theatre, we can see that Hospital 1 has a very volatile return to theatre. So if I would be sitting on your board, or if I would be part of your clinical governance, I would be very concerned being Hospital 1 without investigating why that is happening. When we look at Hospital 2, and Hospital 2 will be here talking to us today, Hospital 2 is actually performing very well, and it has been since 2012, and those return rates to theatre are very, very low and below national and below state average. So they are doing something right, and that's where we want to learn how can we improve patient care, how can we improve that patient's journey, surgical journey. In addition to that, I know we are not identifying individual surgeons, but we are identifying every single issue identified by the peer review assessors back to the hospital. So if you do have a good quality assurance management with your own hospital, you should already know all these issues that we are identifying. You should already know where the area of concerns are. We are just a tool, an external peer reviewer that will reinforce those internal messages. So most recently, we have moved into a more punitive arena where we started producing hospital performance reports. And this definitively came through the Targeting Zero recommendation. No, we are not identifying them because we are covered by qualified privilege, but we are openly identifying the results to the Department of Health, Safer Care Victoria. And we do notify the hospitals who they are, so Hospital 172 should know who they are, and also Hospital 129 will know who they are, but we are not identifying the counterparts. Again, this is a little bit outside the scope of VASM. And the other reasons why we are not doing that, because we do not have the denominator data. We know, yes, how many patients have died. We know how many errors were in that small pool, but we do not know how many patients survived the journey, and we do not know how many cases of morbidities have occurred. So therefore, we can't give a good perspective. So one funnel plot focuses on avoidable mortalities, and VASM is the only state that collects that information. And the second graph, as you have seen, focuses on the avoidability of the death based on the clinical management issue identified. So being that delay in diagnostic or delay to surgery. The first one is just black and white. Was this death avoidable? Yes, no. So what are we doing with the information that we have received? We make a lot of recommendations, being that through our annual reports, case note review booklets, seminars, visits to the hospital. We cannot implement, we can recommend. However, we work very closely with NZISM, we work very closely with the college, with the professional development department, and we have created guidelines for hospitals to use, for instance, mortality and morbidity reviews. We have created position statements on how to act, when we encounter, those called futile surgeries. So we actively try and reinforce those educational messages. You will not see VASM necessarily doing those or divulging those messages directly to you, but then hopefully we are some sort of contributors for that. So I'm going to have a slight twist on the slide that Ewan had a little bit earlier. We know that any change takes time. So exactly the same data that Ewan presented from 2012, I'm presenting from 2000. So this is not VASM data, may I say. This is the VAD data from the Department of Health, and we've done this as an additional exercise in one of our scientific publications. However, you can see the mortality rates since 2000 have dropped from 0.6 to 0.29%. So is VASM contributing to that? I would say yes. Are we making a difference? Hopefully we do. Are we the only factors that are contributing to that? No, and we would never claim that. We anticipate that the contribution comes from the surgeons themselves, the hospitals, the department, and we work collaboratively towards achieving that goal. So are we making a difference nationally? We wanted to know. So initially, VASM produced this scientific publication, and then we wanted to see, is this trend occurring also nationally? And we know that the surgical journey for the patients has become safer around Australia. When we look at the population growth, we know that in the larger states, there's definitively growth. In population, there's higher number of surgeries, but lower number of mortalities. So we know that surgical care is improving. And now that we only have 4.2 adverse events identified, the rate in which we can improve, it's going to slow slightly down, but we wouldn't want it to dissipate. But when we look at this particular rate from 2012 in Nguyen's presentation, perhaps all the way to maybe 10 years down the track, we can see a similar drop in mortality rates and hopefully achieving that true target zero. It's going to be hard because human error will be still existing. So why keep this educational focus? Because that's what we preach to our children. We don't punish them when they do well, and they remember those things, what they're doing well. So we want to learn from those good performance, and we want to improve patient care that way, rather than discourage surgeons to be open and change truly the culture. Because we do not want a society where surgeons can't have the same platform to discuss issues. So how we are ensuring that we are making a difference? This is a secondary KPI that VASM set for themselves. And we know that surgeons are very busy, health professionals are very busy. And we're already taking away a lot of time by completion of all those forms. So to ensure that we make a difference, we try and disseminate our messages through scientific publications, or when surgeons or trainees have time. So we set up an app with all the cases from VASM and NZISM, and a surgeon has to type a particular area, perhaps DVT prophylaxis, or just a specialty, orthopedic, and all the lessons learned from the patient's journey, they can be at anybody's fingertip. And this is a free app, so there's no charge to it for our fellows. So this is what we're saying about ourselves. Yes, we are making a difference, and we think that the surgeons have changed culture. But when we provide our assessments back and evaluations back to the fellows, we want to know if they have changed anything in practice. And this is per verbatim. This is not something that VASM made up. Surgeons do say, and in our surveys, we find 80% of the surgeons value the audit process, sometimes resent it, and we understand it, particularly trauma sites that would have lots and lots of mortalities occurring, and some of them would be truly unavoidable. We understand it can be a burden, but the majority of surgeons understand that this is providing educational value back to the fellows. So this is what we said about ourselves, and I know we heard some contradictory information, but in reality, we had 2 independent reviews. And one that you would be familiar about, which is, through the targeting zero, but we have had 2 sets of aspects consulting reviews. And in the initial recommendations, they had 27 areas of improvement, which VASM successfully implemented 25. And 5 we couldn't implement because it was outside of scope and financial resources for VASM to perhaps conduct a morbidity audit on all the cases occurring in Victoria. And if we would get the funding, yes, perhaps we could be doing something like that, and we could come up with rigid rules around it, but unfortunately that wasn't feasible in the current structure. And in their second round of recommendations, they came up with 5 areas of improvement, and we have successfully implemented all those five areas of improvement. We want to improve, and we want to make VASM valuable to everybody, most of all to our patients, and we want to eliminate, obviously, surgical mortalities that are due to errors. But how we do that safely, that is the question. And we want to continue, we will improve, but we will improve in a way not to obstruct and not to alienate our surgeons and perhaps our hospitals from the audit system. So we would like to work together with you and come up with feasible ideas of how we can achieve that. And I hope that a little bit later on, Philip can touch on some of the plans that we are trying to implement for our future directions. And most importantly, we would like to monitor our audit loop to identify any new areas for improvement. I would like to acknowledge all our collaborators, obviously our fellows, our hospitals, academics, and of course the VASM staff for their support, and our funders, the Department of Health, because without them we wouldn't have a project. Thank you.